So welcome all to the today's session about combined hormonal contraceptive FSRH guideline. Okay, so we begin with our quote, Master MRCOG with concept oriented clarity. So CHC, that is combined hormonal contraceptive containing ethinyl estradiol, can be started by medically eligible women up to and including day 5 of natural menstrual cycle without the need of additional contraceptive. So when we want to start about this combined hormonal contraceptive up to day 5 of cycle, no need of additional protection. Okay, so CHC containing ethinyl estradiol can be quick started by medically eligible women at any time with advice to use additional contraceptive precaution for 7 days. So when it is started up to 5 days, no additional contraceptive is required. If it is started anytime after that, she can start on any day of the cycle. But for first 7 days, the additional contraceptive is required if it is reasonably certain that the woman is not pregnant. So if it is to be started at any time in the cycle, you have to make sure that she is not already pregnant, and additional contraceptive precautions will be required for 7 days. Okay, but if it is started within first 5 days including the 5th day, then no additional contraceptive is required. Okay, so first thing, the it is reasonably certain that the woman is not pregnant and a high sensitivity UPT is negative even if there is a risk of pregnancy from unprotected sexual intercourse in the last 21 days. A follow-up high sensitivity UPT is required 21 days after the last UPC, that is unprotected sexual intercourse. Okay, so first thing, it should be reasonably sure that the woman is not pregnant. Second, high sensitivity UPT should be negative. So if suppose if you have started this combined hormonal contraceptive on day 18 of the cycle, then precaution will be give 7 days of additional contraception. Okay, and do high sensitivity urine pregnancy test. If it is negative, then you will start her on oral contraceptives, additional contraception for 7 days. And uh, when was the last intercourse? After that, we will repeat high sensitivity UPT after the 21 days after the intercourse. Is it clear? Is it clear?
Yes, sir.
Yeah. Okay, so most evidence suggests no association between the weight body mass index, that is BMI, and effectiveness of combined oral contraceptives. So it has got no association with the weight or BMI. Limited evidence suggests a possible reduction in the patch effectiveness in women more than 90 kg. Okay, so when there is a contraceptive patch, this contraceptive patch will be effectiveness may be reduced if the women's weight is more than 90, more than or equal to 90 kg. Women who have had a bariatric surgery should be advised that the effectiveness of COC could be reduced. So one has to be very cautious in bariatric surgery. So with respect to the UK MAC, in this situation, with respect to the bariatric surgery and all, we will see the end of the lecture. Okay. So women using enzyme inducing drug should be informed that the contraceptive effectiveness of CHC could be reduced during the use of enzyme inducer and for 28 days after the stopping. Suppose a lady is taking enzyme inducer drug for a short duration. Okay, then there is a possibility that the effectiveness of the CSC will be reduced during the use of the enzyme inducer as well as up to 28 days after stopping the use of this particular enzyme inducing drug. Okay, so one has to give either alternative contraceptive or additional precautions are to be used. Okay, so women using enzyme inducing drugs should be offered a reliable contraceptive method that is unaffected by enzyme inducers. Most of the time they ask you the question about these enzyme inducer drugs. Okay, so the drug interactions and all, we have another separate lecture for it, so that we will cover that time. Okay, so women taking lamotrigine should be advised that CSC may interact with lamotrigine, and this could result in reduced seizure control or lamotrigine toxicity, and the risk of using CSC could outweigh the benefits. So uh, when the woman is on combined oral hormonal contraceptive, in that particular case, the lady on lamotrigine for epilepsy, There are two possibilities. Okay, one thing is that it will reduce the seizure control, and second thing, there can be lamotrigine toxicity. Okay, so these are the two things which we should remember. Okay, and the risk of using CSC could outweigh the benefits. Okay? Now coming to the progesterone receptor modulators. So what is the clinical recommendation? Women should be advised to wait for 5 days after taking ulipristal acetate for emergency contraception before starting CSC. Now suppose a lady has taken ulipristal acetate for emergency contraception. For emergency contraception in oral category we have two. Okay, one we have oral LNG and second is a ulipristal acetate. Suppose a lady has taken ulipristal acetate in that particular for emergency contraception, in that particular case, she should wait for 5 days before starting the CHC. So if you are given a scenario, please see what is used for emergency contraception. So it may be LNG, it may be UPAC, or it may be copper IUCD, whatever it is. Okay, but if it is a copper IUCD, the same copper IUCD for used for emergency contraception can be continued as a routine contraceptive. Is it clear to you? Because for emergency
Yes, sir.
contraception, we have three options. One, go for LNG. Second, go for UPAEC. These are oral, two options. Third one is a IUCD. Okay, copper IUCD, not any IUCD, copper IUCD. If it is a copper IUCD, in that particular case, the same will be continued. But if it is a oral, that will act only as an emergency contraception. And she will require regular contraception, for which if she is using combined oral contraceptive, then if it is a UPAEC, she cannot start immediately. She has to wait for 5 days. This particular thing is going to be very important. It is an important concept to understand. Okay. So women should be made aware that they must use condoms reliably or abstain from sex during the 5 days waiting, and then until their contraceptive method is effective. Okay. Okay. So this particular, so 5 days of condom and until the contraceptive method. Suppose if it is a combined oral hormonal contraceptive, in that particular case 7 days of additional precaution will also be required. Okay. So use of CSC for contraception may also be associated with non-contraceptive. Then health benefits. Use of CHC can reduce heavy menstrual bleeding and menstrual pain and improve acne. So these are the non-contraceptive uses. Use of CSC may be beneficial for women with PMS. Use of CSC, particularly continuous CSC regime, can reduce the risk of recurrence of endometriosis and after surgical management. So HMB, dysmenorrhea, acne, PMS, uh, endometriosis related symptoms, okay, after surgical management. So these are the non-contraceptive uses. Along with that, you have PCOS. Okay, so the it can be used in the management of acne, hirsutism, menstrual irregularities associated with PCOS. CSC use is associated with a significant reduction in the risk of endometrial and ovarian cancer that increases with the duration of CSC and persists for many years after stopping the CSC. So there is a reduction in the risk of endometrial and ovarian cancer if there is a use of CHC. Okay, and it is dose dependent. Okay, so even if it is stopped, then also the effect will persist. So which cancers are it has got a preventive role? One is endometrial, second is ovarian. The use of CSC is associated with a reduced risk of colorectal cancer also. Okay, so endometrial, ovarian, and colorectal cancer protective role. Health risk. Now coming to the health risk, what we have seen up till now, the non-contraceptive benefits and role in other prevention of other malignancies, in which we have noted three. One is endometrial, second is ovarian, third is a colorectal. Okay. Now let's talk about the health risk associated with the combined hormonal contraceptives. So current use of combined hormonal oral contraceptive, combined hormonal, not oral, combined hormonal contraceptive is associated with increased risk of VT. Some CHC formulations are associated with a greater risk of VT than others, and it depends on the progesterone type and the estrogen dose. So VT risk. So what are the determinants? One, is dependent on the progesterone, type of progesterone and the dose of estrogen. So these are the two important determinants. Current use of CSC is associated with a very small increased risk of myocardial infarction and ischemic stroke that appears to be greater with higher dose of estrogen in COC. Okay. We have seen VTE. VTE, it is the type of progesterone and the dose of estrogen. Then cardiovascular, myocardial infarction, and other is a ischemic stroke, and that will depend upon the dose of estrogen in the COC. Women should be informed that the current use of CSC is associated with increased risk of myocardial infarction and ischemic stroke, but that these events are extremely uncommon in CSC users. Use of CSC by women with significant additional factors for arterial disease should strongly be cautioned or avoided. So if she has got a arterial disease, in that particular case, it should be cautioned or avoided. Women should be advised that the current use of CSC is associated with a small increased risk of breast cancer, which reduces with time after stopping the CHC. So increased risk of breast cancer. Protection against three cancers we have seen: colorectal, endometrial, ovarian. Increased risk CA breast. And women should be advised that current use of CSC for more than 5 years is associated with a small increased risk of cervical cancer. Risk reduces over time after stopping the CSC and is no longer increased up 10 years after stopping. Okay, so increased risk of CA breast and small increased risk of CA cervical cancer. Okay, is it clear? Is it clear up till now?
Yes, sir. Yes.
Okay, so here we have seen the risk which are associated with the CHC use. Okay, now what are the clinical recommendations? So assessment for the medical eligibility for CSC should include medical conditions, lifestyle factors and family history we need to take into account. Drug history should identify any prescribed or non-prescribed drug that could affect the effectiveness of oral contraceptive, as such contraceptive, and the any prescribed or non-prescribed drug that could itself be affected by the contraceptive. So the drug can have effect on the contraception, or the contraceptive can have an effect on the drug, like what we have seen with the lamotrigine. Okay, because there can be reduction in the uh, level of seizure control, or there can be toxicity of the lamotrigine also. A recent accurate blood pressure should be documented for all women prior to first CSC prescription. BMI should be documented for all women prior to CSC. So only what is required before you starting combined hormonal, one is a good history taking. You need to record the blood pressure and the BMI. So these are the only two things: good history taking. Second, record in physical examination only blood pressure and the BMI. Okay, these are the two things which are important. Pelvic examination is not required prior to the initiation of the CSC. So sometimes they can ask you about this, that the mandatory requirement before CSC. They can give only the history, then history plus blood pressure, history plus blood pressure plus BMI, history plus blood pressure plus BMI plus pelvic examination. Okay, but the pelvic examination is not required. The other option can be history plus blood pressure plus BMI plus pelvic examination and the breast examination or the cervical screening set. Okay, so pelvic examination is not required prior to the initiation of the CSC. Breast examination, cervical screening, testing for thrombophilia, hyperlipidemia, diabetes, liver function test are not routinely required prior to initiation of the CSC. Okay, so all these things are not required before you start with a combined hormonal contraception. Is it clear to you? Is it clear? Shall we go ahead?
Yes, sir.
Yeah.
Yes, sir.
So COC containing less than or equal to 30 micrograms of ethinyl estradiol in combination with LNG or norethistral. Okay. Women should be advised that routine annual review of their contraception is recommended during the CSC use. So annual review is important. Women trekking to higher altitudes. Okay. Above 4,500 meters or 14,500 feet for period of more than 1 week may be advised to consider switching to a safer alternative contraceptive method. Okay, so these are certain special situations. If there is a trekking to higher altitude, the altitude also more than 4,500 meter or 14,500 feet. Okay, and if the travel is more than 1 week, she should consider switching to safer alternative contraceptive. From the CHC, the safer alternative contraceptive should be used. Then women should be advised to stop CSC and switch to an alternative contraceptive method at least 4 weeks prior to planned major surgery or expected period of limited mobility. Because if it is going to be major surgery, post-operatively, risk of VT will be increased. Otherwise, also when the lady is on oral contraceptive, the risk of VT will be increased. So these are the patients. If she is planning some surgery, then 4 weeks prior to the planned surgery, the CHC should be stopped and alternative contraceptive is to be advised. Okay, so CSC can be used by medically eligible women for contraception until the age of 50 years. So till what year it can be used? It can be used till 50 years. However, what is the UKMAC for CSC with respect to age? That we will see in the subsequent slides. Okay, but CSCs are safe until the age of 50 years. CSC can be considered for use by medically eligible women until age 50 as an alternative to HRT for relief of menopausal symptoms and prevention of loss of bone mineral density as well as for contraception. So up to 50 years, one for contraception and other for HRT, it can be used. So CSC is highly user dependent. If used perfectly, the risk of contraceptive failure is very low. Okay, it is less than 1% failure, but with typical use it is estimated to 9%. Okay, so remember these failure rates. With perfect use less than 1%, with typical use up to 9%, there can be failure rate with combined hormonal contraception. Okay, effectiveness could also be affected by drug interactions and malabsorption. The CTP, that is combined transdermal patches, could be less effective in women who weigh more than 90 kg. Okay, so when we are talking about combined hormonal contraception, mainly drug interactions, then this CTPR with respect to weight, transdermal patches can be less effective and malabsorption can be issue with COC only. Remember, with the one which we are taking orally, not all CSC. All CSC will have drug interactions, but malabsorption will have only one which is taken orally, while rest of the things which are not taken orally, malabsorption will not have effect. Okay, and with respect to age, we have to cautious about the CTP. Okay, combined transdermal patches. Okay, so the progestrogens that are components of CSC are sometimes grouped by the generation according to the time they were first marketed as constituents of COCs. So first generation we have norkestrone, second generation we have levonorgestrel, third generation we have desogestrel, gestodine and norgestimate. Okay, so NET is a first generation. LNG, that is levonorgestrel, is the second generation. Then in third generation we have DGN, that is desogestrel, gestodine and norgestimate. And newer ones we have drospirenol, dinogest, normegestrel acetate. Okay, so drospirenol is the newer generation, dinogest is also newer generation, and normogestrel acetate is also newer generation. Sometimes classified as a second generation. LNG is one of its active metabolite. Okay, so norlegestromine is a metabolite of norgestimate. Okay, so norgestimate is a third generation, and norlegestimine is a metabolite of norgestimate, and etrologestrel is an active metabolite of desogestrel. Okay, so in third generation we have desogestrel and norgestimate. So norgestimate, the active metabolite is a norlegestromine, and desogestrel, the active metabolite is a etenogestrel. Okay, so co-cyprondiol containing 35 micrograms of ethynyl estradiol cyproterone acetate as an anti-androgen is indicated for management of moderate to severe acne and hirsutism. This is also one of the SBA which combined hormonal contraceptive is indicated for severe acne and hirsutism. It is a co-cyprondiol which contains 35 micrograms of ethynyl estradiol and cyproterone acetate, which is an anti-androgen. Okay, so women using cyprendiol for these indications do not require additional contraceptive. So if the lady is taking it for severe acne or hirsutism, she will not require any additional contraceptive. Okay, so what methods of CSC are available in the UK? So there are currently three methods of CSC which are available in the UK. One is a COC, that is combined oral contraceptive pill. Then second is a CTP, that is combined transdermal patch that releases average 33.9 ethinyl estradiol and 203 micrograms of norelgestromin per 24 hours. And third is a CVR, that is combined vaginal ring that releases ethinyl estradiol and etonogestrel at a rate of 15 microgram and 120 microgram respectively. Okay, so we have COC, CTP and CVR under the CHC. Combined hormonal, okay, so combined hormonal contraceptive can be oral, it can be transdermal or it can be vaginal. So oral is a COC, transdermal is a CTP, and combined vaginal is a CVR. Okay, both will contain ethinyl estradiol. Okay, the progesterone will be different. Then withdrawal bleeding may be heavy, painful, or simply unwanted. So the HFI may be associated with the symptoms such as headache and mood change. Okay, so during the hormone-free interval, this hormone-free interval is going to be very, very important. Now remember, this HFI may be associated with the symptoms such as headache, mood change, etc. Ovarian suppression is reduced. 20 to 26 and follicular development occurs during the HFI, particularly with the COC containing lower ethinyl estradiol doses. Okay, so ovarian suppression is reduced and follicular development occurs during the HFI, particularly with COC containing lower doses of ethinyl estradiol. So error in pill taking. So if the pill taking errors are there or patch or use, they are not used correctly around the time of HFI, that will result into the extension of HFI, risk of ovulation will be there and there will be potential risk of pregnancy. Here you should understand, so whatever is the problem is with HFI. Okay, so if this HFI gets increased because of the irregular taking or the miss pill around this particular time, there will be high chances of this ovulation. Okay, so because ovarian suppression is reduced around the time of HFI. Okay, now, coming to the combined oral contraception. The majority of the COC in the UK is designed to be taken at 28 day cycle with 21 consecutive daily active pills followed by 7 days of HFI. So, what is the standard regime? 21 plus 7. So, 21 days tablets, 7 days either gap or another pill. Okay. So, this 21 by 7 is the standard regimen. Okay. Following, there will be 7 days of HFI prior to starting the next packet of pills. The first 7 pills will inhibit the ovulation and the remaining 14 pills will maintain the ovulation. So when the pack is taken for 21 days continuously, the once she takes first 7 pills, then the ovulation is inhibited and this ovulation remains suspended for another 14 days if she takes the pills continuously. Okay, so this is what is the principle in oral contraception. You should remember the first 7 days needs to be taken continuously. If she takes continuously, then the ovulation is inhibited and after that it will be maintained. That is why in the subsequent slides when we will discuss about the missed pills, this particular thing will or the logic is going to be very, very important. Then coming to the combined transdermal patch. One patch is applied to the skin and it is worn for 7 days to suppress the ovulation. So patch again should be worn for 7 days so that it will suppress the ovulation. Thereafter, the patch is replaced on a weekly basis for 2 further weeks. The 4th week is a patch free to allow the withdrawal bleed, same like oral contraceptive. But only thing is that it is weekly application. Oral contraceptive was to be taken daily. Here it is a transdermal pack, weekly application. But the first patch should be continuously applied for 7 days. That means the patch should not get dislodged or removed. Okay, Then there will be ovulation, effective suppression of ovulation when the patch is in place. Okay, so again, when we will discuss about the mist pills or the removal of the patch, all these basic concepts are going to be helpful. Now, third is a combined vaginal ring. One ring is inserted into the vagina and left in place continuously for 21 days. Now, when it comes to the single ring will be effective for 21 days. Okay. After a ring-free interval of 7 days, to induce a withdrawal bleed, a new ring is inserted. So, again, 21 days you will have one vaginal ring followed by 7 days of HFI, then a new ring will be inserted. So is it clear to you about combined oral contraceptive, then transdermal patch and vaginal ring? Is it clear to you?
Yes, sir.
Okay,
Yes, sir. Yes, sir.
so the concept is same. Only thing is that tablets are to be taken daily, then patches weekly, and vaginal ring is for 21 days. Okay. Now we have two regimens. Okay. When it comes to the oral combined hormonal pill, we have two regimens. One is a standard that we have seen 21 plus 7. Okay. It is not combined oral only. It is all combined hormonal. Okay. So when this combined hormonal, the standard is just 21 days for active pills or one ring or three patches, because the ring is for 21 days and patches will be for weekly. So you go for these and 7 days of HFI. This is the standard use. But there is something which is called as tailored use. In the tailored use, what we have, so you give 21 days pills or one ring for 21 days or three patches, but reduce the HFI, that is hormone free interval, to 4 days. So from 7 days it is reduced to 4 days, because HFI is associated with the side effects. Okay, so most of the side effects of these CHCs are seen with this. Okay, that is why, so to reduce the side effects, we can reduce the HFI from 7 days to 4 days and start with the new one, new pills, new ring, new patch. Okay, so this is one way of tailored use, that is reduce the HFI. Okay, second is the extended use or tricycling, in which what is done, take tablets for 9 weeks. Okay, so 3 packs of 21 active pills or 3 rings. Okay, one ring for 21 days. So go for 3 rings. Okay, that is 9 weeks, or 9 patches consecutively, and then the HFI will be taken for 4 days or 7 days. Either of these can be taken. So you extend the cycle for 3 cycles. So continuously. Okay, so the cycle will become long and HFI you can maintain for 4 or 7 days. Okay, so what will happen, the HFI will come after a long time, then you can give HFI of 7 days or you can give HFI of 4 days. Okay, then flexible extended use, in which you can give continuous more than 21 days. So instead, so one pack, even if it gets over, then continue the pill or the patch or the ring until she gets the breakthrough bleeding for 3 to 4 days. Give HFI of 4 days only. Okay. So this is something like that. She will continuously take the pills till she gets bleeding. She will continue to take the patch till she gets breakthrough bleeding. She will continue to take the rings. Okay. Whatever is the rings are every 21 days. Patches are weekly. Okay. So that the contraceptive is to be used continuously till you get the breakthrough bleeding. So that is a flexible extended use. And second is a continuous use, where these active pills patches are used continuously and there is no HFI which is given. Okay, so these are the tailored uses. Okay, now when can CHC be started? CHC can be started by medically eligible women up to and including day 5 of natural cycle without need of any additional protection. This we have seen. Okay, if at all it is to be started at any time, then we should be sure that she is not pregnant, reasonably sure. And second, high sensitivity urine pregnancy test should be negative. Okay, and we have to repeat the test after 21 days. Now there are certain criteria for reasonably excluding the pregnancy. Dr. Sinchana, can you see this particular slide? Is it a readable slide?
Yes, sir. Yes, sir.
Can you read this?
Yes, sir. Criteria for reasonably excluding pregnancy. Healthcare practitioners can be reasonably certain that a woman is not currently pregnant if any one or more of the following criteria are met and there are no symptoms or signs of pregnancy. 1. She has not had intercourse since the start of her last normal menstrual period, since childbirth, abortion, miscarriage, ectopic pregnancy, or uterine evacuation for gestational trophoblastic disease. She has been correctly
Yes,
and
wait.
consistently.
Now, wait here. So,
Yes.
there should be no intercourse either during the natural cycle or following the childbirth or abortion or miscarriage, ectopic pregnancy, any uterine evacuation for GTD, and after this particular event, there should be no intercourse. Okay, go ahead.
Second one, she has been correctly and consistently using a reliable method of contraception. For the purpose of being reasonably certain that a woman is not currently pregnant, barrier methods of contraception can be considered reliable, providing that they have been used consistently and correctly for every episode of intercourse.
So, these are the criteria for reasonably excluding the pregnancy. Okay. So this is the second. She has been correctly and consistently using reliable method of contraception, including the barrier method of contraception, provided it is used correctly. Okay, next.
She is within the first 5 days of onset of normal or natural menstrual period. She is
Hmm.
less than 21 days of postpartum, non-breastfeeding woman. She is fully breastfeeding, amenorrheic, and less than 6 months postpartum.
Yes,
She is
wait.
within first.
Now these are the three things to say that reasonably excluding the pregnancy is possible in the postpartum period. For breastfeeding women it is different, and for non-breastfeeding women it is different. Okay, for non-breastfeeding women it is only 3 weeks, first 3 weeks following the childbirth, during which, okay, we can exclude the pregnancy. Okay, then if she is fully breastfeeding for 6 months, but it should be fully breastfeeding, she should be amenorrheic, and she should be less than 6 months pregnant, so that we can say that pregnancy is excluded. Next.
She is within the first 5 days after abortion, miscarriage, ectopic pregnancy, or uterine evacuation for gestation trophoblastic disease.
This we have seen already. Okay.
She has not had intercourse for more than 21 days and has a negative high sensitivity urine pregnancy test, able to detect HCG levels around 20 milli international units per ml.
uh, what is high sensitivity UPT? That means the test which will be able to detect SCG level around. So if the blood has got a SCG level around 20 millimeter, and if that test can detect up to 20 millimeter, then it is called as high sensitivity UPT, and that should be negative. Okay, and she should not have had intercourse for more than 21 days. Okay, so these are the conditions where we can reasonably exclude the pregnancy. Okay, now we will see about starting combined hormonal contraceptive and requirement for additional contraception. Okay, so when these hormonal contraceptives are started, CHC, either oral or a ring or the patches, and what is the need for additional contraceptive. Okay, so for oral contraceptive, it is additional contraception for 7 days, contraceptive precautions, or 9 days for estradiol, valerate, or dinoges COC. Okay, so situation, women having natural menstrual cycle up to and including the 5 days. So if it is started up to and including the 5 days, will there be any need for additional precaution? There will be no additional contraceptive will be required, and requirement for HSUPT, that is high sensitivity UPT, 21 days after the last UPC is not required, because it is started, we have reasonably excluded, because she is up to and including the 5th day of the cycle. So in that, no additional precautions are required, or contraceptive are required, and no HSUPT is required. However, if it is started at any time, okay, if it is reasonably certain she is not pregnant or HSUPT is negative, then we have to use this particular additional contraceptive, and we will have to do HSUPT, high sensitivity UPT, 21 days after the last UPC, that is unprotected sexual intercourse. Is it clear to you? Is it
Yes, sir.
clear? So up to
Yes, sir.
5 days, not required. After 5 days, additional contraception plus HSUPT will be required. Now, if the woman is amenorrheic, at any time, if it is reasonably certain that she is not pregnant, what are the criteria that we have seen? HSUPT is also negative. She is amenorrheic, you can start, but use the additional contraception for 7 days, and after last unprotected intercourse, do the HSUPT. Okay. Now, if she is taking LNGC, if she has taken emergency contraceptive, in that particular case, we can start the CSC immediately. Additional contraceptives are to be used for 7 days. HSUPT is required. Okay. Now, after UPAEC, that is ulipristal acetate, we have already mentioned that 5 days we have to wait. If it is a ulipristal acetate, we will wait for 5 days to start CHCs. Okay, so 5 days after taking UP, you will start again additional precaution for 7 days, and HSUPT will be required 21 days after the last UPC. This is clear to you. If it is about if the scenario mentions about emergency contraception, check what emergency contraceptive is given, whether it is LNG or whether it is UPA. If it is LNG, start immediately, but do HSUPT after 21 days and 7 days additional precaution. If it is UPAEC, you will wait for 5 days after UPAEC, then you will start, but additional 7 days precautions, and you will give HSUPT after 20 days. Now coming to the childbirth. With respect to childbirth, always there are two things. One is a breastfeeding and another is a non-breastfeeding. So up to 6 weeks following the childbirth, so from 6 weeks following the childbirth onwards, okay, it can be started. However, 7 days of additional precaution and HSUPT will be required. Okay, provided she is breastfeeding after the childbirth. But if she is not breastfeeding, then without any additional risk factors for VT from 3 weeks following the childbirth, and with additional risk factors from the having VT, then 6 weeks following the childbirth. Okay, so if she is breastfeeding and if she is not breastfeeding, then the combined hormonal contraceptive, how they are to be used. Okay, if she is breastfeeding, after 6 weeks you can start. But what is the UKMEC category after 6 weeks for oral contraceptive? Any idea? UKMEC category for oral contraceptive after 6 weeks. We are saying that it can be started safely after 6 weeks. Oral
Two,
contraceptive. Huh?
it can be considered with caution.
Yeah,
Two.
it UKMEC 2. It will become UKMEC 1 after 6 months only. You got
Okay.
it?
Yes, sir. Yes, sir.
UKMEC 1 after 6 months. But you can start
After
between
6 months.
6 weeks and 6 months. It will be UKMEC 2.
Two.
Okay.
Yes.
Provided she is breastfeeding. Okay. If she is not breastfeeding, then we need to take into account whether she has got a risk factors for VT or not. If she does not have risk factors for UPT, you can start from 3 weeks onwards. Okay. And if she has got a risk for VT, then you start 6 weeks following the childbirth. Okay. So this history is going to be very, very important if she is not breastfeeding. Okay. And always 7 days of additional precautions and HSUP. Okay. So after abortion, miscarriage, ectopic pregnancy, up to and including 5 days, nothing, no additional precaution. Follow pregnancy testing as per local protocol after these pregnancies. And if you start after 5 days of all this, then definitely she will require additional protection for 7 days. Okay. Now switching from hormonal contraceptive to combined hormonal. Now she is already on hormonal contraceptive, from where she wants to shift to combined hormonal. Okay. Say for example, she is on another CSC, or she is on traditional POP. So she is from POP she is changing to CSC, or from one CSC she is going to another CSC. What are the things which are important? So she is switching from CHC to another CSC. When to start? Start on the day after the last active pill, COC, CVR or CTP. So that means immediately after the last active pill, the another CHC can be started. So here HFI is not given. Okay, so requirement of additional contraceptive is not there. If a HFI is taken, then the need for additional precautions and the emergency contraception should be assessed on individual basis, taking the account of correct use before the HFI. Okay, so if she is shifting from one CST to other CSC, omit HFI. If the HFI is taken, then assess for need for additional contraception and uh, emergency contraception if required. Okay, so is this clear? If she is changing from one CSC to another CSC, we don't have to give HFI. So okay, if she is using CVR and she wants to shift to COC, so CVR vaginal ring is for 21 days. Okay, so one ring will be removed and immediately the COC will be started. Is it clear to you?
Yes, sir.
Yeah, okay. Now coming to the traditional POP. She is taking traditional POP and she wants to shift to CHC. Okay. It can be started immediately if the POP has been used consistently and correctly. So immediately after the POP, the CSC can be started. Additional 7 days of precautions will be required because the mechanism of action is different for POP and mechanism of action is different for CSC. POP, within how much time the it will show effect, and what is the main mechanism of action of POP is through the cervical mucus, while it is by inhibiting the ovulation, and the inhibition of ovulation is required 7 days. We have already mentioned the first 7 tablets will suppress the ovulation and next 14 days will maintain that suppressed ovulation. Is it clear to you? Is
Yes, sir.
this concept clear? So if she is shifting from POP to CHC, the additional 7 days of contraceptive will be required. Here they have given the expression, the primary mode of action is not inhibition of ovulation and therefore additional precautions are required in case of ovulation occurs before contraceptive efficacy of CSC has been established. Okay. The cervical mucus effect may be maintained, but there is no guarantee. Okay. So that is why we have to give additional precaution. Now, if she is taking progesterone only anovulatory method, disogestrel, so POP has got two things. No, one is the traditional POP and the POPs which also has got anovulatory action like a disogestrel only pill or injectable or implant within the license duration of use, and she wants to shift to CSC. Then what is the guideline? It says start on the day after the last POP, start at any time up to and when the repeat injection is due. So if it is injectable, at any time up to when the repeat injection is due, and start any time up to and when the implant is due for removal. Okay, so till the active duration of this particular either injectable or implant, you can start CSC. Additional precautions are not required, and the primary mode of the actions of this is inhibition of ovulation. CSC will suppress the ovulation by the time the inhibitory effect of the previous method is lost. So here we have seen the traditional POC which act by thickening the mucus, you need to use the additional 7 days of contraceptive. But the hormonal method or progesterone method which suppress the ovulation such as disogestrel pill or injectable or implant, in that particular case if you are shifting to CSC, additional 7 days of precaution is not required. Okay, so the reason is that because they all act by inhibiting the ovulation, and CSC will suppress the ovulation by the time the inhibitory effect of the previous method is lost. Okay, then suppose she is shifting from LNG IUS. Okay, within the license duration, she wants to shift to CSC. It can be started at any time. Then additional precautions are required for 7 days. Okay, if there has been UPC in the last 7 days, the LNGI should be retained for 7 days. Okay, so suppose she wants to shift from LNG IUS to CSC, in that particular case 7 days of additional precautions are required. Now if there is a intercourse prior to the starting of the CSC in the last 7 days, in that particular case keep the LNGIUS for 7 more days, because in these 7 days the CSC will have effect of anovulation. Okay, is it clear? So from
Yes,
LNGIUS
sir.
to CSC,
LNG.
additional contraception for 7 days is required. Okay, you can remove the LNGIUS, but give 7 days of additional precaution. If there is a sexual intercourse in the last 7 days, then prefer to keep the LNGIUS for 7 days. Okay. Now switching from non-hormonal method to combined. Now non-hormonal we have copper IUD. Okay. And non-hormonal method other than copper IUD. Okay. Now if she wants to shift from copper IUD to CSC, up to and day 5 of menstrual cycle, nothing will be required. No additional precaution. Okay. Copper IUD can be removed at the same time. Now if she is changing at any time, okay, after the day 5, at any time other time of the menstrual cycle, additional 7 days of precautions will be required, and additional precautions are required unless CSC was started 7 days prior to the copper IOD removal or copper IOD be left in situ until the CSC become active. So if at any time we are using, then 7 days of precautions are used, or start 7 days prior to the cycle, remove IUD, means IUD should be kept for 7 days, and then the oral contraceptives are continued. So that means oral contraceptives are started, they are continued for 7 days, IUCDs are removed and continued with the oral contraceptive. That is one way. Second, if it is started any time, then keep the IUD for 7 days more. Okay. Now non-hormonal method other than IUD, and she wants to shift. Okay. Up to and including the day 5 of the menstrual cycle, not required. At any time, yes, 7 days will be required, and consider follow-up pregnancy test if amenorrheic or a negative HS high sensitivity UPT should be obtained. Okay. Now, these are the typical and the perfect use failure rates. So this table is going to be very, very important. You can take the photograph of this. Always SBN EMQ can be asked from this. Okay. Failure rate of various hormonal methods. Suppose she does not use any method, in that particular case, there is a 85% chance of failure. Then fertility awareness methods, various methods are there for fertility awareness. With perfect use, maximum 5%, 0.4 to 5% is the failure rate. While typical use, it is 24. Female diaphragm we have seen, female and male barrier contraceptive we have seen what, 2% and 5% we have seen. Here they have mentioned 6%. Previous it was a 5%. Okay. So 6% and 12% with the, sorry, with the diaphragm it is 6% and 12% we have seen. Condom was a 5 and 95. Okay. For female condom. For female diaphragm, 6% failure rate and 12% failure rate with typical use. For male condoms, 2% with the perfect use and 18% for the typical use. Okay. Now combined hormonal list, here it is 0.3. Okay. Combined hormonal. Okay. Then progesterone only pill, again 0.3, and with typical it is 9. Okay. Though these figures are there are so many numericals, you can remember. If you look at these particular figures well, you will be able to remember this. Like oral contraceptive as well as POP both have a 0.3% with perfect use, and typical is 9. Progesterone only injectable, that is DMPA, 0.6% perfect use, and sorry, 0.2% perfect use and 6% with the typical use. Copper IUDs, copper IUDs 0.6% with a perfect use and 0.8% with a typical use. LNG-IUS, LNG-IUS is 0.2% with typical and perfect use. Okay. Then progesterone only implant, that is the least one. Okay. That is 0.05%. Okay. Both typical as well as perfect use. Okay. Then female sterilization 0.5, that is 1 in 200. Okay. This is 1 in 2000 progesterone implant. Sometimes they give you figures like this, so you should be able to convert immediately. 1 in 200 is 0.5, 1 in 2000 is progesterone implant 0.05. Okay. and vasectomy is 0.1% with a perfect and 0.15 with typical. Now, what do you mean by typical with respect to vasectomy? If they do not follow the instructions following the vasectomy, okay, there are certain instructions following the vasectomy. If they are not followed, the failure rate will increase. Okay. Now, what are the key points? Is it clear? Because there are SBS which are asked on this. Pills you should remember
Yes, sir.
0.3, 0.399 for both POP as well as COC. Okay. Then go together with LNG IUS and copper IUD. See, here it is 0.5, zero point 0.2, zero point 0.2. Sorry, 0.6, 0.8. For copper IUD, it is 0.6, 0.8. LNG, 0.2, 0.2. Okay. And list is with implant 1 in 2000. Okay. One that is 0.05. Female sterilization 0.5, zero point 0.5. Okay. And this diaphragm and this we have already seen. Okay. Now coming to the key points, effect of vomiting and diarrhea. Okay, so it can reduce the COC effectiveness. So oral contraceptive effectiveness will be reduced if vomiting is within 3 hours after the pill or diarrhea is lasting more than 24 hours. Follow missed pill rules. So in that particular case, missed pill rules. This is also EMQ. Okay, they will give you scenario and they will mention that there is a vomiting within such and such time, or there is a she is suffering from diarrhea. Then whatever is a protocol for missed pill that you will have to follow. Okay. Then if there are persistent symptoms, consider non oral contraceptive methods. Okay. If this diarrhea and vomiting is persisting, in that particular case, non oral contraceptive methods will be better. Okay. Now coming to the VTE risk, COC increases the VTE risk 3 to 3.5 times versus non users. Then absolute risk of VTE is 5 to 12 per 10,000 women per year versus 2 per 10,000 in non-users. Okay, so 3 to 3.5 times the risk is increased. About 1% of VTE cases are fatal. Okay, VTE risk with different COCs. Low dose COC, that is ethinyl estradiol dose less than 50 microgram with cyproterone acetate or desogestrel or gestodine or drospirenone, the risk of VT is 1.5 to 2 times higher. So it depends upon the type of progesterone. Okay. So you have a low dose, but if you are using LNG, then with LNG there is a lowest risk of VT. But if you are using the progesterone as a cyproterone acetate or desogestrel or gestodine or drospirenone, there is a 1.5 to 2 times higher risk as compared to the LNG. Okay. Norge estimate COC, the risk is similar to LNG. Okay. Then VT incidence, non-CSC and non-pregnant women is 2 per 10,000, while the Danish study says 3.7 per 10,000 women in years. Okay. You need not remember this, but on non-pregnant and those who are not taking CSC, it is 2 per 10,000. This you figure you remember, and this increases to 5 to 12. Okay, this 2 per 10,000 is for non-users. For COC users is 5 to 12 per 10,000, and the if they are using this particular progesterone, it will be further 1.5 to 2 times higher. Okay. Now recommendation for additional contraceptive precaution when switching from combined hormonal contraception to another method. Now here the situation is that she is shifting from combined hormonal method to another method. Now this another, it can be another CHC, it can be POP, it can be DEMPA, it can be implant, it can be LNG-IUS or anything. Now it depends upon the what she is using and when she wants to change. Now she is using currently CSC week 1 or day 2, days 3 to 7 of HFI. So first week or up to 7 days of HFI, day 3 to day 7 of HFI, and no IPSI since last start of the HFI. Then if she is shifting to these, in that particular case, condoms are to be used for 7 days if she is using another CSC. If she is using POP, then 2 days of condoms are required, because POP action on the mucus will come within 2 days. If the DEMPA, implant, LNG, IUS are to be used, then the additional contraceptive will be for 7 days. Is it clear? Are you getting this particular concept?
Yes, sir. So what
Oh,
is the column after LNG, sir? It is blocked by
this
which one?
no,
Ah,
just a minute. Uh, I'll just check it what exactly it is. Maybe need for the UPT will be there most probably. Okay.
okay.
So now here the situation is that she is using currently CSC but shifting to another CSC or other hormonal method like a POP, DMPA, implant, LNGIVs. In that particular case, additional contraceptives for 7 days is required except POP where 2 days of additional contraceptive is required. Okay, provided it is started within first week or day 3 to day 7 of HFI and there is no UPC since the start of HFI. Okay, now week 1 or day 3 to day 7 of HFI and there is a UPC from the start of the HFI. Okay, now there is a difference between the two. Then what we will have to do, continue the CSC until 7 consecutive days taken, then advice as for week 2 and week 3. So then follow this particular advice. Okay, so she will take the CSC for 7 consecutive days and further advice will be like this particular next block. Okay, now she is shifting from CHC to another hormonal method in the second or third week or day 1 or day 2 of HFI. Okay, so here it was a day 3 to day 7 of HFI without UPC and with UPC. Now here it is, but it is or it was in week 1. Now here it is week 2 or week 3 or day 1 to 2 of HFI. Okay, now if it is a second week or third week or in the first 2 days of the HFI, if she is shifting to another CSC, POP, DEMPA or implant, nothing is required. No additional contraceptives are required. Okay, because week 2 and week 3 already 7 days continuously she has taken the CHC that has caused the suppression. You got it? So when she is using another CSC, nothing is required. POP action will be there within 2 weeks. Nothing is required. Same is for DEMPA and IM implant. Okay. But if she is using LNG IUS, if day 2 of HFI, follow advice for days 3 to 7 of HFI. Okay, whatever is the advice for days 3 to day 7 of HFI, condoms for 7 days. And if day 1 of HFI, then none. Okay, so if she is shifting to LNG in second or third week, in that particular case, if it is the first day of HFI, then nothing will be required. But after that, second day of HFI, then condoms will be required for 7 days. Okay, so with respect to LNG there is a little difference, while in second and third week rest of the things here she does not require any additional contraceptive. Okay, is it clear?
Yes, sir.
So continue CSC in case of this particular first week or day 3 to day 7 of HFI. Now first 2 days of HFI are very safe, but from third day onwards the HFI is going to be risk for the failure of contraceptive. So she will continue until 7 continuous days, and the further advice will be there, like for CSC, POP, DMPA there will be no additional precautions will be required. But for LNG IUS, if it is a first day, then no additional precaution. But if it is day 2, in that particular case, 7 days of condoms will be required. Okay, so these are the guidelines for shifting from one method to another method. Okay, so that finishes the topic today. Thank you.